Good morning, and thank you for coming. When you have so many other options to go to, you decided to come here. So I'm actually surprised that many people are interested in structured reporting. Now, I was supposed to give a talk to counter whatever he said, but I don't think I can say anything really. This was an outstanding, kind of high-powered. So I'll give you the low-power version. Okay. So they asked me to say, what is the American solution? I don't think I want to say that. There are issues and there are possible solutions. So we don't really have one solution to this. So how many people in this audience use structured reporting of any kind? Okay, nearly half. So I don't know why you're all here. You're already doing it. How many use it for every report? Every report that goes out from your departments, use structured. And so the others, I assume, just use it for specific indications, specific diseases, etc. Okay, that's where I think we kind of belong. So his was a very powerful presentation of a very high-end methodology. Now, variability in Röntgen reports is nothing new. It's been studied back in 1907 by Preston Hickey. Showed that reports were handwritten personal letters that used terminology, making them ambiguous and confusing. And that's one of the issues with reports in general. This is true today too. Notice that especially surgeons who like to be critical of us, in particular rotated radiography, contributed very little to patient care. So in fact, when Hickey became the Röntgen Ray president, that's the yellow journal ARRS, he advocated and developed the use of earliest standardized reports. In fact, he said you couldn't become a member unless you submitted 10 reports, and then he would check them. And if you met the criteria, he would let you become a member. But the other board members thought it was too strict a criteria and said, probably nobody will be able to join, so just leave it. So it never became a standard. So it's been around for a while, and it's been going back and forth, and it's still here. Recent report in the Spine Journal looked at lumbar spine reports from 10 imaging centers in a single geographic area in the States who imaged the same person and were compared. Reports compared for concordance and following parameters, disc bulge, herniation, all these things that we report. 49 distinct findings were reported, and only 30 findings noted in all reports. And the global kappa was about 0.2%, which is very low, okay? So that's what we are dealing with. As was pointed to by our moderator, there are perceived obstacles and disadvantages for routine use, which have been quoted for a long time. So time-consuming. Initially perceived decreased efficiency and productivity was quoted. They're difficult to standardize across different institutions, disciplines, medical centers, etc. Cardiologists may want something, you may not want the same thing. They don't care about pulmonary nodules, they want to know only about the vascular structures. All these things have to be dealt with. And radiologists thought that their autonomy in giving their personalized reports were being eroded. And residents and trainees lose the art of dictating reports, whatever that is, the art of how to dictate a good report. I think this is what our moderator was talking about. The time dwell on the images is decreased because you're spending more time looking at the report, less time on the imaging findings. So increases error rate. Some studies have shown there's some mild increase in that. And radiologists always, we perceive that the benefits really are not for us. They're benefiting clinicians and possibly hospital administrators and insurance companies, and really not themselves. These are the perceptions. The implementation, surprisingly, in the US has been actually more accepted in non-academic clinical practices. Almost most of the outside studies which get from the referring hospitals, which are non-academic, all have structured reporting. It's something they have just decided to do. If you're starting one, I think you need a champion in radiology. Somebody has to spearhead this. And it's just very hard to get it going, as he probably did in his department. I'm assuming that you took the lead and got things going. You have to have input from everyone. Every single stakeholder in the process has to be, including trainees, because they're going to be the ones who are going to be using it. Residents, fellows, you have to get buy-in from the referring physicians and subspecialists in oncology. When we did the first one on pancreatic structured reporting template, which is now adopted by the NCCN, was in 2012. But it was at the urging of one of the pancreatic surgeons that my colleague and I, Mahmoud Al-Hawi, who's the first author, wrote the first paper in radiology on structured reporting in pancreatic cancer. But we had to get buy-in from endoscopic ultrasound group, gastroenterologists, radiation oncologists, oncological surgeons. Everybody who deals with the pancreatic cancer has to be bought into the system, shown everything. These are the things that we are looking, what are you looking for? They have to tell us, because they know much more than we know about some things. So all of them have to have input into this. And then this is for complex studies, as I said, local oncology, medical, surgical, radiation, everybody, as well as national diagnostic radiology and other relevant subspecialties have to be brought in, and they have to have full acceptance. It has to be rolled out very slowly and has to be flexible in changes, because you may find something you never thought about, you have to change again. So do that. And then the final endorsement of the structured reporting templates, at least we found for the pancreatic cancer one that we submitted, we presented at major radiology meetings as well as subspecialty meetings and their societies, and had them all agree that this is the final template before it went out. And then agreed to have a joint publication in their journals as well as ours. So we had radiology, we had to call the editor. I called the editor and asked him, I said, we want to put this template out. I know radiology doesn't do this, but this is a structured reporting. Gastroenterology is going to publish the same one simultaneously. So if we do simultaneous, so nobody jumps one ahead of the other. So it is a simultaneous publication in both journals. So when you have that, you have some chance of success. And the reason I say some chance, it took us nearly 2 years to get our group, our own radiology people, to use the template. So it takes a long time to do this. But now there are many numerous things, like Dr. Persiegel very nicely showed, that are helpful to us, because vendors have got interested in this, and this is becoming more common. The organized format should include identifiers, clinical indication, examination, identifiers, and technique, findings, impression, and recommendations. And many of this now comes standard. If I just say pancreatic cancer template in my PowerScribe, automatically it populates everything. And you just have to fill in the things. But the vendor-sponsored ones are much more advanced, are much easier, because they have drop-down menus and click buttons. We have to enter a lot of data still. Findings should include a list of the required elements that are required in studies and the description of the relevant anatomy. You have to define terms that lead to greater clarity and definitiveness to produce comparable reports, reproducible reports, etc. So what are the benefits? There's several studies that have been published. I'll just highlight some of them. Reduction in diagnostic errors. You can see there's a study, 400 studies, 12.4 overread, had clinical significant changes, 22.2% were emergent findings that had to be changed. So in structured reporting, you find more findings or relevant findings. Reduced omission of required anatomical detail. Study of 100 knee MRI reports, quality improvement measures, including application of structured report. Missing detail dropped from 6.3 to 0.4%. Another study showed lumbar spine MRI images. Important incidental findings were not mentioned in the original report. And then many of the incidental findings are really like cysts in the kidney, which don't matter, but occasionally abdominal aortic aneurysms were missed or not reported on in a few small percentage of cases. So if you have a structured method of looking and reporting, you probably will include those. This is a study that Dr. Persigal showed. This is the increased confidence of surgeons in adherence to guidelines. There's the study done by Olga Brook from the group in Boston, where they reported surgeons were more confident of the radiology findings after structured reports were applied to standard reports. This probably, I don't know how much it applies to y'all, but in the States, revenue capture is an important thing that at least the administrators look on. Meaning, do we lose money because if ultrasound reports have a anatomic requirement that has to be mentioned, and if it's not mentioned, the insurance will not pay you. So you have to capture that. Some people have talked about patient-centric reporting, which I don't know how that goes down well. There's a report for clinicians, but you have a more simplified version for the patient itself. And of course, the big thing people talk about is data mining and research. You have everything standardized, so you can pick out what you want and then analyze from multiple series of patients. Here's the pancreatic cancer study by Olga Brook. You can see there, the last line is what's important. Surgeons were more confident about tumor resectability assessment and surgical planning when structured reports were used. Because if you look, for example, the portal vein and SMV involvement was discussed in only 72% of patients with non-structured reports, whereas when it's structured, it's in all of the reports. Here's another one looking at suitability for liver transplantation. 2 surgeons analyzed radiology reports, and the things they were looking for, the presence of T2 disease and exception qualification, and those points were improved from 80 to 94% after structured reports. So again, surgeons more confident about tumor resectability assessment and surgical planning using structured reporting. This is one looking at including anatomic details and revenue impact. Here's one showing that structured reporting may improve documentation and mitigate lost revenue because it can result in 2.5 to 5.5% in lost professional income due to insurance audits. Again, this is when in some ultrasound reports a critical piece of the finding is not put or an anatomic organ is not mentioned, they assume you didn't scan it. So therefore, they just decline reimbursement for that. Here's another one, ultrasound reports again, looking at 470 studies per month, and the incomplete reports dropped to 2% reports compared to 15 before the implementation of structured reporting. So again, this is the potential for revenue capture. And then when you have common data elements, you can do, this is for more for research purposes. So if you mention that there's tumor in vein, you can look at all the patients who have tumor in vein and look at their prognostic significance, outcomes, et cetera, by just capturing that one line in multiple reports and then getting a large data set. This was already shown, so we already have multiple templates available. The RSNA has been working on this, and this is the one that Dr. Persigal mentioned. I'm not going to go into details about it, but a lot of people have done different work on it, and you can see there's an oncorenal mass, there's a renal stone, GU has 51, GI 66 templates, et cetera, so you can pull down the ones that you want to use. And obviously, the different societies, the American College of Radiology have provided organ and tumor-specific templates for liver, prostate. And then this is the vendor one from Mint looking at rectal cancer staging. Obviously, there are many other companies. I just use this as an example. And then there's one also for follow-up for screening, staging, as well as therapy response evaluation, a more sophisticated one. Now, some subspecialties are going even further. They say traditional structured reporting is not tailored to appropriate clinical situations. So, for example, the neuroradiology group and the head and neck group have come together, and they are creating structured reports tailored to specific diseases. So they have an MS one and a head and neck cancer one, which looks like this. This is from their article in AJNR last year. So contextual reports were favored over standard ones, but of course they're asking the right people. You ask neurologists and neurosurgeons and otolaryngologists, they're going to say it's great because it fits exactly with what they want. Now, I'm going to end quite early because, as I said, there's not much to say after he's gone through that, and I'm just giving you an overview. Tell you some things that we have done, because we don't have any sophisticated systems. We basically have templates for all the malignancies, for special diseases like MR enterography and CT enterography. We have a template, which is our own, and we just populate it, or when we dictate, when we say MR enterography template, it brings it up and populates it, and then we just fill in the details. Still a lot of work, but gets rid of the technique. Everything else is auto-populated. Some things that we have done using our own software settings. It's not a big thing. You can ask it to capitalize the side of whatever you're describing, whether it's right kidney, left kidney, etc. This is one where we tend to make mistakes a lot, I especially. Okay, and then somebody calls you up and say, did you mean right side when you said left? And you look and say yes. But this may be easier to see when it pops up in your report, and you go like, is it really the right? Because now you're emphasizing the right side. So you look again and make sure it is the right side. So when you're editing your report, it may be easier to see that. This is just something we have done. And words like no, because frequently in the PowerScribe, when you say no, it sometimes just ignores that word. And just as metastatic disease, you say no metastatic disease in the liver, and it just says metastatic disease, and they call you up and they say, we don't see any. What are you saying? So no evidence, no, not, all of that is highlighted so that you can then. And this is the so-called tall man letters that's been advocated by all these institutes. And basically, this was used for drugs because you can see dobutamine and dopamine end in the same letters, but you need the top letters, front letters are the ones that make the difference. So that's one thing we do. We also standardize everything to centimeters. Okay, so we can configure the packs to say every measurement will be in centimeters rather than, because sometimes the temptation is when you're dictating, you begin with CM, and then you go into MM, and then you come back, and it's like they're just looking at numbers, 7, 6, so we do that. And the other one is we have a few words that we convert automatically. So if you say IPMN, it automatically dictates intraductal papillomucinous neoplasm. It saves a little bit of time. Another one we've done in our pelvic ultrasound one is, for example, for the pelvic ultrasound, when the tech is doing the procedure, sorry, we have technologists who do our ultrasounds for us. I know most of you guys probably do your own ultrasounds, but the system, they've got a software which, when they're measuring each organ, it actually puts it there, and and I'll show you, so then when the report comes up, it automatically populates the length, the dimensions, so you don't have to go and put in each one. Similarly, note I've highlighted no fibroids in this, but if there are fibroids, this one says 2 fibroids. So in addition to the uterus, you can see that there are fibroid 1, fibroid 2. So whatever the tech labels as fibroid 1, wherever that location is, anterior fundal, it'll go on your report automatically. So you don't have to be reporting there's an anterior fundal fibroid measuring blah, 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 submucosal. She decides you agree, then you just auto-populate it. Just saves a little bit of time. That's only for the ultrasound unit we have had this. I'll talk a little bit about what the future could be. Follow-up recommendations and guidelines for incidental findings could be auto-populated using a CDS, the critical report notifications also for masses like lung mass or solid renal mass can go on. Future, you may have radiation dose tracking. I don't know whether you have already got that in your system. In your packs you have, right. So it can show you from each study, like in a graph, what the dose tracking is. And in the future, there may be multimedia enhanced reports Mint, I think, already has this in other companies, but you have embedded images in your reports, graphs, tables, lab values, tumor biomarkers, all of this could be there. And then, of course, serial lesion size with lesion management tool, which already is around, and you can display it in graphs and in tables. These may be coming. So the group at MGH studied the clinical decision support tool and the effect of a workstation doing that on radiologists' adherence to pulmonary nodule guidelines modeled after the Fleischner Society. They looked at that in 409 patients, and they found that overall guidance was higher after they had the CDS tool. So was 95% versus 45% before it was used. And here's it shown graphically. And you can see when CDS is used, the big numbers in green, there's nearly 95% of the time that when the tool was available, that people used it. As I said, structured reporting is also automatically now linked to voice-driven workflow, templates linked again to voice-driven statements. So once you say something, it just brings up everything, the protocol, whatever we used, and the different things, technique and template, and then you just have to put the things inside. As I said, you can import reference images soon and measurements from comparison reports, and interoperability with other systems like auto pull down of recent reports such as pathology slides reports, endoscopy images. All this is possible in the future. These are all things people are talking about. What about the use of AI in, this is first a little bit about non-interpretive domains, what it can help with. It can prioritize exams on the system. So if there are stat reads, those go up to the top, which means that's the first one you'll be reading. And it may go by history, question, stroke, hemorrhage, abdominal aortic aneurysm, those get prioritized to go up. Anything coming from the emergency department may get prioritized to go up. And then, of course, AI may be used to detect some of these problems and bring them up to the front. Extract relevant data from other information systems to help you in image interpretation. So even as soon as the case comes up, all the relevant data will be coming up instead of you having to hunt through the medical records to find them, the electronic medical records. These things could be auto-pulled up. It can help you select protocols based on the clinical data and check for prior contrast reaction. If the patient had a prior contrast reaction, it can flag it so that you know there's a patient who's coming up next week or whatever. Make sure they have the steroid prep or whatever prep that you use. And more into the future, possibly these are the areas I think where AI is actually going to be even more helpful than actually assisting us in interpreting the images, which may be one, but there are many, many more applications, I think, in the area of non-interpreted domains. It can improve image quality. For example, where there's respiratory motion, it can throw out all the images that are useless and not helpful and keep the ones that will be good. Decrease radiation dose, MR scan time, et cetera, et cetera. Now, how many use this diagnostic certainty lexicon? Okay, I can tell you we don't use it, but it's a very interesting one to use because this is published from the group at Sloan Kettering way back in 2015. They apparently obviously had it since 2012. So they made all the clinicians give what was their certainty of a diagnosis, of a finding, which helped the clinicians much more. And I'm sorry if you can't see it, but I'm going to highlight some things. You can see when they said may represent, that is intermediate likelihood, that was the highest number people used. It sounds like me, which means I'm on, like, I don't know, maybe. But the other ones with high numbers include diagnostic of, consistent with, compatible, means you have very high confidence rate that this is what it is. And you can see their numbers there, 45, 46.5. Okay? So similarly, on the lower end of the scale, very unlikely, unlikely meant low likelihood, very low likelihood. and those were in the 47 to 40% range. So this is the agreement among radiologists on the preference of selected phrases to convey diagnostic certainty. And this is a study done by the group at Boston, and they found that while people said this in a survey, many had disagreements about what level of certainty they used, and when they said something, what did it actually mean to them, etc. So there's a lot of variability in how we convey these findings to our patients and to our referring physicians. So they proposed this algorithm and said, if you're 100% confident, simply state the diagnosis. Say, this is compatible with Crohn's, or this is Crohn's disease. Stop. Or use the term as diagnostic. If you're not confident 100%, then go to the lexicon below. You can use very unlikely, meaning low likelihood, unlikely, low likelihood. May represent is intermediate likelihood, which unfortunately is something I think we use a lot of. I'm speaking about myself. High likelihood and most likely. So use consistent with or compatible only within the established diagnosis of that. So that's what they propose. We haven't done it in our own institution. I can see by this show of hands that a few people are using it, but I think it's a pretty reasonable system to use to help patients as well as our referring physicians. Well, I hope some of that is giving you a little bit of what we do. We don't have a very high-end system, but we do a few small things here and there. We're a kind of a mixture, a hodgepodge of things. And I hope some of what I said may be helpful to your practice. Thank you very much for your attention.